think we're not pouring enough resources for end-of-life care in the home. I think a lot of care that's provided in the home is still very patchwork and very small. The majority of people getting home care, for example, will get 1 or 2 hours a week, right? Is that enough for a good quality death? Nowhere close to that.
We want to engage people early. If people have, let's say, a year or 2 to live, we want to help them live their life as well as they can. We don't ordinarily do that in medical care. We focus on the disease and the medical treatment, and we don't focus enough on the person.
Awareness of death adds to the poignancy of life. Helps us really appreciate the richness and importance and fullness of each day. Can we use each day well? If we thought we would live forever, we probably wouldn't. So these reminders for ourselves, for our loved ones, that death happens, it can be a blessing in life.
From the Zoomerplex in historic Liberty Village, the Zoomer with Libby Znaimer.
Welcome to the Zoomer. Most of us don't like to talk about it, but along with taxes, it is the one thing we all inevitably face. Death. In the last few years, we've started to ask the question, what makes a good death? There's been an increase in advanced directives and medically assisted deaths, along with the advent of a new caregiving profession, the death doula. We have a wide-ranging panel of experts to delve into how society is changing the way we face the end. But first, let's tee up the topic.
Zoomers are changing the way we approach the prospect of death, bringing the conversation into the open. The question is, what is a good death? Is it one free from distress and suffering? Is it timely and equitable access to palliative care? Or is it one that is in accord with our wishes, including access to medically assisted death? Last year, there were approximately 278,000 deaths in Canada. And while surveys show that most Canadians would prefer to die at home, few are able to accomplish that. According to the Canadian Institute for Health Information, fewer than 1 in 6 people who died between 2016 and 2017 received publicly funded palliative home care. In Canada, medical assistance in dying is legal, and the number has increased steadily. Advocates want the restrictions to be eased so that more people will be able to decide the date of their demise. For some, it is a final act of control. For others, the prospect of heaven. But planning for a good death has become a part of life.
Let's begin with the process of facing the end. Dr. Roden, let's start with you. You deal with terminally ill cancer patients every day.
Well, I think when people are diagnosed with cancer, perhaps with any cancer actually, it's a life-changing event. It's a traumatic event. The most common reaction is overwhelming fear and anxiety. And it's hard actually for people even to think about it initially. Then they have to face what lies ahead. First, it's often about deciding about treatment. Will they pursue an aggressive treatment? Will they not? What will be the treatment course? And then there's a whole set of predictable challenges people have to face. How do I talk to my family? What about the changes in the relationships that occur? What do I need from my partner? How will I live my life in the time that remains? And how will I face the end? We know that many people benefit from help. These are difficult challenges. Medical care routinely does not help people address those challenges. It tends to be focused much more squarely on the cancer or the medical illness that people are facing. So we know we need to do a lot more to help people navigate those challenges and then to face the end. Without that, we know that serious depression is common, symptoms of demoralization is common, and suicide actually is a common outcome.
But there's a difference between getting a diagnosis of cancer and facing the treatment and all of that, but getting a terminal diagnosis is a very different thing. What are the stages of people wrapping their heads around that?
My guess would be that any diagnosis likely feels terminal when you're first hearing those words. And even though many advances in medical science have likely made more diagnoses, or some diagnoses less risky, or maybe risky is not the right, less scary than others, I think whenever anybody hears those words, I think the first thing when they hear cancer especially, they hear cancer and I'm dying. And so whether or not there is great prognosis, whether or not they have received a diagnosis that may be for a cancer that's highly curable, I think still when we hear those words, where we automatically go to is, this is it.
I disagree with that. I think that's changing anyway. But still, I mean, it is a process, but at a certain point, often, people realize they are going to be fine, and a lot of cancers are really quite curable. But I'm asking about when you start to consider that, you know, you may not make it out of it.
Yeah, and you know, I think with some diseases it's quite simple, you know, in the sense that, you know, it's definite that you know, this is what's going to kill you. But I think in reality, you know, as we get into modern medicine, the more we realize that life and death is not so simple, right? And a lot of us, you know, in the room even have a lot of medical conditions that, you know, might kill us, might not kill us. And I think the key with death and dying is to not treat it as, you know, this cut dry line in the sand where, you know, go past it, you're gonna die, but treat it as part of living, right? That death is part of living, and that death's journey is part of the living journey.
Kayla?
I always talk about when people come to death cafes to talk about dying and death, it really turns into a conversation about life and living, which speaks to what you were just saying. About what it really is about until the end. And through my hospice work, I found that until someone is dead, they're still very much alive. And that's what we need to be focusing on.
Marilee, I'm remembering, I guess it's old-fashioned now, those 5 stages of grief. Do they apply where you're angry, denial, depression, acceptance? I forgot one in there.
Okay.
Does that still apply?
I mean, it applies. However, it's when Dr. Kubler-Ross did those and did that research to uncover those, they were done on people who had received a diagnosis, but they were never intended to be in chronological order, and they were misconstrued that way. So, I mean, often it's people bouncing back and forth between all of those stages, per se. But Dr. Alan Wolfelt is actually a grief counselor in Colorado, and he has identified the 6 stages of mourning. So, because grief begins at diagnosis for the dying person and their loved ones. So, I mean, it's similar to Kubler-Ross's original stages. Yeah. Thank you. But they've evolved a little bit, if you will. So.
What do you find in your practice, Dr. Kelly?
I'm just thinking, I've had patients tell me I refuse to die the proper way. Like they've seen this list of stages too. And I think in any given day, you can have many different kinds of feelings about it. Yeah.
Absolutely.
Our work is mostly with people who are survivors of someone having died in the family. Although we do see now people with ALS, they're often interested in learning, can I learn to accept and deal with this? Because for them, the outcome is certain. The timing may not be entirely certain, but as opposed to some cancers, it will kill them, yeah.
One thing is that sometimes for the physicians, it's easier for them to suggest another treatment than to talk about that.
Exactly. I think physicians in this death-denying society, you know, are almost the worst culprits, right? Our healthcare system often is set up to just talk about cure, 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 right? And you're right, Libby. It's much easier for us to just say, we'll prescribe you this, we'll send you to this specialist, we'll, you know, provide this treatment, rather than talking about and opening that conversation about death and dying. And the two are not mutually exclusive, right? I think a lot of us in the medical profession and, you know, in society, you know, don't really, you know, think that, you know, you should not be receiving end-of-life care when you're actually receiving active care, right? And so there's this misconception that, you know, if you're receiving active care, that we shouldn't receive end-of-life care, and you should.
Okay. Hold those thoughts. We have to take a quick break, and we'll be right back.
We found actually a good quality of dying and death in a whole range of locations, including hospital, and there's many hospitals now have acute palliative care units, at home, in residential hospices. I would emphasize the point about people dying in the location of choice.
is usually considered the gold standard for the end of life, but only half of all patients dying in Ontario receive some form of it, usually in a hospital, and that is according to the Institute for Clinical Evaluative Sciences. And while most people say they want to die at home, only 20% receive some form of palliative care at home. So why is that? And what are the benefits, not only for the patient, but for the overall healthcare system when someone chooses home care? Tracy.
So without a doubt, the benefits to everybody when somebody chooses home care is an opportunity for the dying person to have the death that they have chosen. And if they can have a death that they have chosen, then not only are they receiving their wishes, but for the family, there is a much greater chance that they are going to be able to go through their grief journey and get back to what may need to be a new normal much more easily, because they've been able to accommodate something that was so important to their family.
I've seen many families where even if they are able to a certain point to care for someone, it's not sustainable, and the home care isn't available, even though it costs the system much, much less money. So what's up with that?
I think actually we should think about people being at home as long as possible. We should avoid, on the other hand, a morality about where people die. We actually have collected data. We've been doing research on the quality of dying and death, and we've found actually a good quality of dying and death in a whole range of locations, including hospital, and there's many hospitals now have acute palliative care units, at home, in residential hospices. I would emphasize the point about people dying in the location of choice.
True.
And many people, when you ask them early on, where would you like to die, and they say at home, they actually have no idea of what it's going to be like near the end of life. It's like a woman who's going to give birth saying, I don't want painkillers for childbirth. Well, when they get there, they may have a different opinion. It's not an easy thing to die at home. You need a proper home environment. You need a team, a family team. You need home care. It's wonderful in some circumstances. In other circumstances, residential hospices or hospitals are actually optimal. So as a system, we need the whole range of services available.
So I agree with Gary that there's a wide range of places where people can die and have a quality of death that's really high. But I think we're nowhere close to getting that mix right. I think too many people, 52% of Canadians, die in hospital. And when you compare that to other places around the world, we're pretty much at the top in terms of number of people dying in hospital. Mm-hmm. And so, while it's true that a lot of people can have good deaths in hospital, I think that's not happening. And to answer your question, we're pouring in more resources in the home. I think we're not pouring enough resources for end-of-life care in the home. I think a lot of care that's provided in the home is still very, patchwork and very small. The majority of people getting home care, for example, will get 1 or 2 hours a week, right? Is that enough for a good quality death? Nowhere close to that.
Yeah, but you make house calls. Mm-hmm. There aren't a lot of doctors, as far as I know, who are willing to do that work.
Yeah, and I hope I don't get my profession in trouble here, but I think we're really failing. I'm a family physician, and I think a lot of family physicians are well-meaning, but people have lives and people are busy as well, right? And so to provide that home visit, right now our system is not structured in a way that prioritizes that part, right? So I think everyone recognizes that when a baby is born, someone needs to be there to catch the baby, right? When someone is dying in their home, we don't have the same expectation that a doctor needs to be there. And I think we need to start changing that.
What does a death doula do exactly?
So a big piece of what we do is education. So we're constantly educating the dying person, educating the family on what to expect and what options are.
Do you do this at their home?
Yes, absolutely. I only am in people's homes. So, so then that way it eliminates the fear, it allows them to know what all of their options are and to let them know what to expect.
You were talking about anxiety before. Do you see that anxiety can lead to people ending up in a place they don't want to be?
I think so, for sure, yeah. I mean, there has to be fear with death, with making the change from, I had this idea for my life and for my family, and now something else is happening. So there's anxiety when what comes along is different than what we hoped or expected. But I think in your case, you would see too that if families are given some time for the anxiety to pass, and they can see, well, we're still okay here, then there isn't a need maybe to call 911 or something else that may be difficult to reverse.
Yep, there's a lot of hand-holding, you know, and a lot of support. And, you know, a lot of times people just even need you to hold space for them to be in that space with their person, you know.
So you want to jump in?
Oh yeah, I was thinking the amazing thing, we're talking a lot about death education and death literacy, and I always advocate for the fact that since nobody's exempt from death, and that the time to start advocating for your end-of-life rights and choices is well before you need them. That's why we need to kind of separate this fear of talking about dying in death and this fear of dying in death to kind of get through that first wall, which is the discussion and the dialogue, and become less afraid of using words like dying, death, terminal, and thinking about what kind of freedoms and rights we'd like to be able to access at the end of life.
Okay, so let me ask this. There's a move afoot here in Canada to change the rules for medical assistance in dying so that people can decide in advance if they're not going to be clear-headed when the time comes. But if the norm is that people change their minds, how do you reconcile those two things?
What a good question.
Well, yeah.
You stopped us in our tracks.
Well, with medical assistance in dying, even with like right up until the moment it's administered, people have to be able to say, yes, I still want this. And so I've been present at a MAID death, and I witnessed the physician saying, you know, do you still want to do this today? If you don't, that's okay. I can come back a different day, or we don't have to do this at all. So I think that's the key, is that, again,
but
it's
people
empowering.
want that changed.
Right.
Yes.
And that's your point.
The dilemma is that if people are approved, especially if they're close to the end of life, the legislation was enacted in order to protect vulnerable people so that they would not have something imposed on them. I think it's had the unexpected consequence of producing a lot of anxiety in people who are approved. They fear that they will lose competence and not be able to have it. And so some people are afraid to take narcotic pain medication for fear it'll affect their cognitive functions. Some people actually, as the case that's been making the newspapers, are saying that they've had to have it earlier than they would for fear of losing competence. So there is a contradiction. If you give substitute consent to someone, they could, for example, take you off a ventilator if you're on a ventilator in an unconscious, irreversible state. But even if you've been fully approved for MAID, assisted dying, they could not give substitute consent for that. So that seems a contradiction to me.
Okay, well, we'll have to pick that up a bit later, but right now we're taking a quick break. Stay right there.
When it comes to a terminal phase, when you know, or our calculator, for example, can tell you that, you know, you have 4 weeks or 6 weeks or 2 months to live, I think a lot of people will make choices quite different choices, different decisions based on that information.
Welcome back. It's the ultimate question that not everyone has the nerve to ask. How much longer do I have to live? Depending on the disease or condition, doctors can often tell you if you have weeks or months or years. And that kind of estimate is part of the art of medicine, but now there is a new tool that is strictly in the realm of science. Using an algorithm, researchers say they can calculate a person's death date using 25 questions about what diseases they have and how difficult it is to care for themselves. Dr. Peter Tanasaputro is one of the researchers behind the algorithm. So tell us about it, please.
Yeah, so it is exactly that. It's 25 questions that we ask people about their health, and it's questions that anyone can answer. One of the reasons why we create this algorithm is to open up the conversation about death and dying, and to really help patients and people and families and caregivers really face the fact that their loved ones might be dying or that they might be dying. And too often we don't do that, right? And too often, not only clinicians, but also patients and families and caregivers, really, deny that they are in fact dying. And so it's supposed to take, like you said, Libby, to take the art out of it and put the science into it and really give them a good, robust estimate.
Yeah, but if people can't face it, they're not going to use the algorithm.
Yeah, so, it's a good question. So how many people want to know, right? So there was a recent
How many
poll.
people do want to know?
So there was a recent poll to some media around our calculator, and the poll, 82% wanted to know about
Really?
when. Yeah, I know, it's
Or
surprising.
82% tell a pollster that they want to know.
No, fair enough. And I think you're absolutely correct. Like, not everyone wants to know, and some people prefer to be oblivious to it. But if you're oblivious to the fact that you're dying, I think it forces you to not, it doesn't give you the opportunity to make choices that are, that really maximizes the quality of your remaining life, right? I think if we're denying the fact that we have only a certain amount of, time to live, I think we might, for example, go out and seek aggressive medical care that might have awful side effects, right? Things like chemo or radiation. Those things are definitely appropriate when, there's a curative disease, but there's often this gray zone when we don't know if you can actually be cured or not. And when it comes to a terminal phase, when or our calculator, for example, can tell you that you have 4 weeks or 6 weeks or 2 months to live, I think a lot of people will make choices quite different choices, different decisions based on that information.
What do you think of that?
Well, I have a couple of thoughts about it. One is just about this question of curative. I think we need to shift the paradigm about whether curative or terminal. Actually, most of medicine is not about cure. Most of medicine is about improving quality of life, prolonging life, and so most cancer treatment, for example, or much cancer treatment, is about prolonging life, improving quality of life. I think one of the things that all human beings have to face also is uncertainty. None of us know how long we're going to live, and we have to live with that uncertainty. And these kind of predictions give you some ballpark figure, but there's a lot of individual variability and unpredictability. I think the turning point for people is not so much, there are people who are going to be cured of their disease and are going to get back to living their life. Other people have a disease that doesn't go away. And we find there's a tipping point when people realize, this is a disease that I don't know exactly how I'm going to live, but it's going to shorten my life. My time is limited. That sets in motion a whole lot of other things. I think the other thing we need to do, by the way, is begin early. We now speak about early palliative care. So we're talking about death, but actually we want to begin this process from the time of diagnosis, manage symptoms, help people make these adjustments and begin to plan from the time of diagnosis. Because we know that things don't go well when people present late with many symptoms, and that's how we end up often with a bad death.
Well, I have to talk about my own experience, that when I was diagnosed with pancreatic cancer, I wasn't managing the pain, and the doctor immediately sent me to palliative care. The first thing I said to the doctor was, palliative care? Like, you're freaking me out. And he said something like, oh, I have some of my patients for a year or two. And it wasn't very comforting, but it was great for managing symptoms. And, I got fired as a patient, which was okay.
Good news, yes.
Which was fine.
Most other countries, palliative care starts at the point of diagnosis. And so even if you look at the original definition of hospice care, it was a philosophy of care that journeyed with somebody from the point of diagnosis. It was never meant to be a building or a time period that's kicked in at some point. And I look at sick kids, and I think they've made some interesting progress because they've changed the wording around their palliative team from being the pediatric palliative team to the pediatric advanced care team. So they've taken the word palliative out of the equation, and that team comes in at the point of a diagnosis so that the family is talking about all possible outcomes.
And you're also now supportive care, because I remember in charitable work that I was doing, so many people saying to me, "Got to change the name,"
Well, there's 2 points of view about that, because, of course, the problem isn't the name.
It's the problem
is the thing.
Yeah.
The problem is the thing.
No, the problem is what people interpret as the thing.
So what we do is educate people about the word, for example, because we want to have the conversation. And palliative care, when Cicely Saunders in London began St. Christopher's Hospice, was about end-of-life care. The term, by the way, was coined by a Canadian, Balfour Mount, because he thought the word hospice was too stigmatized. So a newly invented word, but it was associated with the end of life. Now we associate it with care beginning. So one group of people think we should change the name. Another group of people think we need to educate people about what it means, about early care, psychological, physical, social, spiritual care, from the time of diagnosis through the course.
And it literally means to palliate, right, to ease. And I think we've lost sight of like the original definition of the word.
We have, but people, believe me, have a very visceral
very
reaction to that word.
And hospice even more so.
Yeah.
Oh, yeah.
Hospice means you're dying today.
Or
Not
tomorrow.
literally, or tomorrow.
Yeah.
Yeah.
Tomorrow.
Yeah.
Yeah, and you know, part of me wants to change the word and wants to change, you know, people's perception of the word. But part of me also, when someone's actually dying, also makes, you know, wants them to accept it as well, right? You know, and I think, you know, we can't treat as a taboo word, right? And we are treating as, you know, even around the table as a bit of a taboo to say that palliative care means actually dying and end-of-life care. But in reality, you know, a lot of palliative care is end-of-life care, you know, and that is when I find that I make the biggest difference, you know, in patients' lives, when I can be, you know, with them, you know, in their homes, providing that care near the end of life. And it's true, I think sometimes it's constructive to take it out of that stage, you know, of the end-of-life care, but a big part of end-of-life care and palliative care, you know, provides really a good death at that end-of-life period. So I'm a bit conflicted about, you know, trying to remove that connotation with end-of-life care.
So to the other professionals around the table, is that algorithm a good thing?
I've done these algorithms. I have 23 years to live. Give or take.
Nice. Give or take.
Is that good news or bad news?
Well, it's news, right? But you can plan your life. If I think I'm going to live 1,000 years, I don't have to worry about getting anything done. But now that I know that there is an end to it, I'm 67, so I've got a while to go. But it's actually helpful to know that when I'm about 90,
might help you plan your finances.
Yeah. So what's that saying? Die broke.
Yes. Well, yeah, but you don't want to live broke.
Yeah.
Right.
So
in your 90s.
But you're right to plan finances, or what do I want to spend my time with? I'm still running a business. I'm having a lot of fun with that. Do I have enough time for my family? What other projects are important to me? So if I have 23 years to go, I can think about how I want to use that time wisely, and that's fine with me.
Okay. We're going to take a break, but we will be right back with more of the Zoomer.
Grief is difficult. It's difficult for the person going through the dying journey. It's difficult for caregivers, for family. Grief begins at diagnosis, and regardless of what the outcome is, a diagnosis is a life-changing experience.
Welcome back. Therapy and pain control are not the only ways to ease the burden of an impending death. Exercise and meditation can be extremely helpful. Deborah Devine takes her classes to hospices, helping both patients and their loved ones through yoga and breathing exercises. Take a look.
Every month, Healing Yoga's Deborah Devine teaches classes here at the Carpenter Hospice in Burlington, Ontario. For the participants known as the Wellness Warriors, there are several physical benefits that include managing chronic pain, firming muscles, and lifting spirits.
You know, it's the most stressful time of their lives, and sometimes you've got other, family dynamics, you've got financial considerations on top of that. So the mind-body benefits of this kind of a gentle yoga practice is really helpful for them. Bring our arms up. Reaching for the sky, wiggling the fingers.
2 years ago, I was diagnosed with cancer, lymphoma cancer, and I've had treatments, and I'm waiting to get my clearance that I'm free of cancer. So I'm here, and I'm enjoying it. It's very relaxing. I meet other people that go through the same thing.
It really helps to create a sense of peace and balance, and especially in the course of doing chemotherapy and radiation, restorative yoga in particular is very beneficial.
It's a great class, a great program. It's good for, I think personally, for a lot of people, for the social aspect.
Enjoy the benefits from it, the social aspect of it, and trying to help other people get through life on a daily basis.
And then our branches, our arms and our hands connecting.
Well, I started in 2011. I was in treatment for colon cancer, going through chemo. So it's a really good support mechanism for that. When you're wondering what the heck's going to go on with you, and to find people that are in, a similar position. So one of it was the community, but another was just the activity. Since then, I'm kind of in a support role myself now here.
Here in Burlington at the Carpenter Hospice, I'm Darren Maharaj for Zoomer News.
We see how yoga can be used to help patients and their loved ones deal with the physical symptoms that come with grief. But many don't even realize the toll grief can physically take on your body, everything from headaches and pain to fatigue and even digestive issues. Marilee, what have you seen?
Digestion is a huge thing for sure, and depression, anxiety can come from that as well. And these sorts of things like meditation can be extremely helpful. Energy healing, I'm a Reiki practitioner, so I have used that with my clients and they find that incredibly helpful as well. And I use it a lot in my grief practice as well. So grief is difficult. It's difficult for the person going through the dying journey. It's difficult for caregivers, for family. As I mentioned earlier, grief begins at diagnosis, and regardless of what the outcome is, a diagnosis is a life-changing experience, right? We tend to look at life differently after receiving a diagnosis or after losing a loved one. Death, I say, or grief puts life into perspective for us.
Paul, what do you do in your practice?
People come to see us if grief is a problem. Grief is natural, and for most, one would hope that it will, over time, soften and one comes back into life. If people are avoiding old friends or situations where they used to be with their partner, I've had people say, I just can't listen to that music anymore, Or maybe it moves to alcoholism, to drinking too much, or the family is feeling they need some help because what they try to do hasn't been enough. So people come to see me or one of my therapists, and we try to give them a roadmap that will be useful without rushing them. You can't say, well, you should be better by now because somebody has a schedule. But in the mindfulness approach, you're looking at acceptance. Partly it means just to be willing to face what is here now, what's true now, which can be different than the story that we had hoped for our lives. Can people learn to be kind and to reconnect with even small things in their current life? And that often is a very important beginning.
You have a program called CALM, which is for the terminal patients and their families. How does that work?
CALM is an acronym. It stands for Managing Cancer and Living Meaningfully. And so it's a program which is organized around helping people both with the practical problems that they have to face. How do I manage my symptoms? How do I talk to my family? What do I do about work? And all of the profound questions that a serious diagnosis raises. What is the meaning of my life? How do I want to spend my life? How do I want to face the end of my life? It's part of what we call early palliative care in the sense we want to engage people early. If people have, let's say, a year or two to live, we want to help them live their life as well as they can. We don't ordinarily do that in medical care. We focus on the disease and the medical treatment, and we don't focus enough on the person. So we know that with cancer, people have a series of challenges to face. And so we've organized this intervention around 4 domains. First domain is around how do I manage my symptoms? How do I talk to my healthcare providers? The second is how do I deal with all the changes to my self-concept, to my identity, who I am, and my relationships. I need something different from my partner than I did before now that I have an illness. The third domain is about meaning in life. How do I want to live my life? We need to reorganize my priorities. We all have to think if we want to be here today, if we are diagnosed with that serious illness. And how do I face the end? And so this is actually done in 3 to 6 sessions over 6 months.
Is it common where a patient wants to talk about it, but there are people in the family who don't want to deal with it? Kayla?
Yeah, I was gonna first say to that, it's really common that anybody wants to talk about it, to dying and death, because it's something that we're all going to approach at some point in our life. But yeah, families have different needs, and denial is really functional for a lot of people. So anybody is in a family dynamic leading up to like an active death could turn to denial as a coping mechanism, and that, like Tracy was saying earlier, the client's needs and the client's clients' desires are always what we're there to serve as home hospice palliative caregivers.
I think culturally sometimes that can have an effect.
Oh, that's
because
interesting.
certain cultures will not talk about it. And so if you are in a situation like that where you may really need to talk about it, but culturally you can't, I think that just adds a whole new layer of challenge.
Well, that's a very important aspect. We live in a very, very multicultural society, so practitioners, I guess, have to be very aware of the different...
The other thing we often hear is that the person who's diagnosed, not only is there a need for them to talk about it, but they also in some ways find themselves in a caregiving role where they're managing the fear and the anxiety of their loved ones. So they're becoming the caregiver when they're giving this news because of how the news is affecting their family members or their loved ones. And so that, again, just makes an even greater need to make sure that we've got lots of opportunity to talk.
When we return, we'll take some questions from the audience.
But with people living longer, my thought is, are people deferring having the conversation about their death plan or what their wishes are? And how do we open that conversation up with our loved ones before a diagnosis?
Welcome back. Now it's time for questions from the audience, and we are starting with Beth. Hi there, Beth.
Hello, everybody.
Hi.
The question I have today is, we're talking about people who have been diagnosed with a terminal illness, but with people living longer, my thought is, are people deferring having the conversation about their death plan or what their wishes are? And how do we open that conversation up with our loved ones before a diagnosis, where you can have a rational discussion? I don't know how that works, or how do you put it in writing? How do we do this?
In death cafes, we have conversation starters, and one of the things that I know when I've hosted them is people often want to take a copy of the conversation starters home to have that discussion over dinner, to talk to their spouses, to talk to their families, because they're like, I love these questions. And they can just be something as simple as, you know, what song would you want played at your funeral? Or what is a perfect death to you? Where would you want to be? So even just little things like that, I mean, you certainly can take it farther to advanced directives, which is a conversation about, or advanced care planning, sorry, about, you know, kind of what your needs and wants are. And that's even on Speak Up Ontario. You know, there's all kinds of those things online to be able to facilitate those conversations.
Thank you.
Thank you.
Thank you. Okay, stay right there. We'll be right back with some final thoughts. Pardon the pun.
On Facebook, John writes, "The word death often freaks people out, but it is something that everyone faces in their life. So why not face it head on and be prepared for whatever comes your way?" On Twitter, Jana tweets, "Death is taboo, so let's keep it that way. I'm 75. I have a lot of life in me. I don't want to talk about my funeral. Why? Because God willing, I'll live till 100. Hashtag death is taboo." Keep the comments coming in. And don't forget to log on to www.thezoomertv.com for full episodes and more.
Welcome back. Our panelists will leave you with some final thoughts, starting to my left.
First, how appreciative I am that we are having these conversations, because conversation does lead to choice. And I think choice is the one thing that we can all offer ourselves and each other, as long as we approach our living and our dying without judgment. And I think the more we come together as a community to help each other, the better opportunity we have to find alternative ways of supporting one another, so that we're not always so much dependent upon what the government may or may not be able to do. So for me, it's bringing dying back to the community and an opportunity to be able to have the discussion about choice.
The challenge for me is, you know, in the healthcare system, and where a lot of care is still being provided, that we need to do better in providing that care in patients' homes. And that starts from the family doctor to the cancer specialist to the palliative care specialist. Everyone needs to play a role.
Absolutely.
And it's not just one single individual, but across the continuum.
It takes a village.
Kayla?
I think just the big piece is that you're never too young or too old to start talking about dying and death. I even think there's age-appropriate discussions for children and youth, and there's discussions up till every age. We're all going to face it ourselves, and likely we're going to face it with our parents and our loved ones as well. So the sooner you start the dialogue, the sooner we can start demystifying death.
Paul Kelly?
I'm just thinking in the mindfulness perspective, awareness of death adds to the poignancy of life. Helps us really appreciate the richness and importance and fullness of each day. Can we use each day well? If we thought we would live forever, we probably wouldn't. So these reminders for ourselves, for our loved ones, that death happens, it can be a blessing in a way.
It's important that we start focusing on treating the whole person, so not just the medical side, but also the holistic side. Medicine has a very small part in end-of-life care, an important part, but dying is holistic, it's not medical, and our bodies know how to do that. So just meeting people where they're at and helping to support them through whatever they want their dying to look like.
We have to provide palliative care, which means psychological care as well as physical care, social, spiritual. We have to provide it early, and we have to be preventive and proactive and not reactive and wait till problems help. It is about helping people live well when time is short, and I think that's the gift for all of us in working with people, is that it causes all of us to reflect on what is the meaning of our own life and how to live it well in the short time that remains for all of us.
Okay, well, we all have to follow our individual paths to find a good death, but if we accept the inevitable, an impending death can become a very enriching time of life. Thank you for being with us. Thank you so much to the panel. We'll see you soon. It's time to zoom out.